Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects, as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Hello and good evening, everyone. Welcome to the NAMS Navigate Medico CME program, and welcome to the final program of this session from Psychiatry Division. So, just to begin with the program, I would like to invite Professor Ajay Kumar Sood for the welcome address to the participants and the dignitaries.
Thank you. Good evening to all of you. On behalf of the National Academy of Medical Sciences, I welcome you all to this Navigate Medico CME program. In this session, this evening, we have with us one of the eminent psychiatrists in the country from All India Institute of Medical Sciences, New Delhi, Professor Atul Ambedkar sir, who is going to deliver a very interesting talk on substance abuse, especially focusing on alcohol and alcohol. So thank you so much and very warm welcome, Professor Atul Ambedkar sir. I'm sure that the practical tips which you are going to give to our participants, especially to our students, will be very, very useful. A warm welcome to you. I also extend a warm welcome to the Chief Coordinator for this series on psychiatry, Professor Rakesh Chadha sir, who is our Honorable Council member also, and he has taken very keen interest in identifying the topics as well as the excellent resource person and experts from all over the country. Welcome, sir, and welcome again for this particular session. For your support and blessing. I also welcome all the distinguished participants. I can see very senior faculty members in the participant as well as the PG student. And my special appeal to the PG student is please take best use of this opportunity. You can always ask your question and queries. You can put in the chat box. And at the end of the session, Honorable Speaker will be happy to answer. So once again, welcome to all of you on behalf of the National Academy of Medical Sciences. Over to you, Dr. Jaswant.
Thank you, sir. So now I would like to welcome one of the distinguished faculty in the India. He is the chief coordinator of this CME and also chairperson for today's program. I would like to welcome Professor Rakesh Kumar Chadha. He is a professor and head of Department of Psychiatry, and he is also chief of National Drug Dependence Treatment Center, All India Institute of Medical Sciences, New Delhi. He is also president-elect of World Association of Social Psychiatry. He is fellow of Royal College of Psychiatrists of UK. He is international distinguished fellow of American Psychiatric Society. He is honorary fellow of World Association for Social Psychiatry. He is also fellow of National Academy of Medical Sciences of India. He is currently associate editor of British Journal of Psychiatry and is handling editor of British Journal of Psychiatry International. He is a recipient of 14 national awards in psychiatry, and he has more than 300 publications to his credit, including 12 books or monographs. So again, I would like to extend a warm welcome to Professor Rakesh Chadha. Chadha, sir, please. Over to you, sir.
Thank you, Dr. Jaswant, Dr. Sood. And good evening, friends. This initiative was taken by Dr. Shiv Sareen and Dr. Umesh Kapil, who are the President and General Secretary of National Academy of Medical Sciences, India. So today we are having last in the series of 6 lectures in psychiatry. And today's topic is on substance use disorders, which will be taken up by Dr. Atul Ambekar, who is my colleague and professor of psychiatry at National Drug Dependence Treatment Center at Almi Institute of Medical Sciences, New Delhi. Substance use disorders are one of those illnesses which are often misunderstood in the community. These are often not recognized as illnesses, sometimes taken as bad habits. So there are a number of misconceptions associated with it. Now it's well established that substance use disorders or drug addiction or drug abuse, these are recognized medical illnesses and there are effective treatments available for these illnesses. So we'll be having discussion about those by Dr. Atul Ambekar. Dr. Atul Ambekar also happens to be Secretary General of Addiction Psychiatry Society of India. He is a member board of directors of International Society of Addiction Medicine. Has been on the addiction board, editorial board of the International Journal of Drug Policy. Has been honorary fellow of School of Criminology, Hong Kong University. Has more than 100 publications. Has been a resource person and expert for UNODC, UNAIDS, WHO, and INCV. And was a principal investigator of National Drug Use Survey of 2019 of the Government of India, which was conducted by the National Drug Dependence Treatment Center. So welcome, Dr. Atul. So over to Dr. Atul.
Thank you very much, sir. I hope I am audible and very. My screen is also visible to everyone. So at the outset, my sincere thanks to the organizers for giving me this opportunity. Now, the substance use disorders themselves are a very vast area. In fact, we run a DM addiction psychiatry super specialty program on management of addictions, substance use disorders. Within them, even alcohol and opioid use disorders, they contribute to the major chunk of the clinical workload which an average addiction psychiatry sees in their practice. To encapsulate everything of that in one single talk would be a challenge for anyone, I suppose. So rather than going for depth in this talk today, what I have decided is that we will touch upon the important take-home points which are essential for everyone. So to begin with, first of all, greetings to everyone on the occasion of auspicious occasions of Eid ul-Adha and Ashadi Ekadashi, both the festivals falling on the same day. We are really lucky to live in such a diverse country. So basically, coming to the importance of both alcohol and opioid use disorders. As Professor Chadda rightly said, there are a lot of misconceptions in the community, in the general population about substance use disorders. Unfortunately, even many of the medical professionals are also not spared of these misconceptions. So misconceptions, inadequate understanding of the scientific and clinical aspects of substance use disorders, they pervade even many of our colleagues as well. So it becomes our duty to not only provide evidence-based, human rights compliant treatment to our patients, but also to periodically take opportunity to educate our colleagues as well as the general community. So coming to first, why the importance of alcohol or opioid use disorders. One is that alcohol contributes to substantial degree of mortality overall throughout the world. About half of the global population is supposed to be alcohol user, current alcohol user, while the prevalence happens to be around 5%. But this is at the global level. There are marked inter-regional and inter-country variation in prevalence of both alcohol use as well as alcohol use disorders. But important thing to remember is, irrespective of whether a person is consuming alcohol in a problematic manner, which means irrespective of whether the person is suffering from any alcohol use disorder, such as harmful use or dependence, the use of alcohol itself contributes to risk of developing many other kinds of health conditions. In fact, alcohol is among the leading risk factors for other kinds of diseases, disabilities, morbidity, and mortality throughout the world. So alcohol, as we know, all now should understand, is really a harmful substance, even if it's consumed in a non-disordered manner. So those who are consuming alcohol in a problematic manner, to the level of suffering from harmful use or dependence, they in fact contribute to the maximum amount of morbidity and mortality contributed by alcohol consumption. Coming to opioids, this is data reported from just around 2 days ago from the World Drug Report released by UNODC. And over the years, as we can see, since 1990 onwards, the relative contribution of opioids among all other drugs has been high and is consistently growing higher in terms of its contribution to disability as well as mortality. So opioids are also a drug of major concern. Coming to our own country, around 15% of Indians, they consume alcohol. So in terms of global, the prevalence of alcohol use, it's much lesser as compared to the global prevalence. But a disproportionately high prevalence of alcohol use disorders is the highlight of Indian alcohol consumption pattern. So fewer people consume alcohol, but among them, many others, they consume alcohol in a problematic manner, to a very high extent. And that's why we have around 5.7 crore people affected by alcohol use disorders, around 2.9 crore people suffering from alcohol dependence who urgently require treatment. Coming to opioids, again, our opioid use statistics are 3 times that of global average. Around 2.1% of Indians use opioids as opposed to 0.7% globally. And we have as many as 77 lakh people suffering from opioid use disorders. So clearly, these are worrying trends for India, considering that the harms which can caused by use of any psychoactive substance, particularly in case of alcohol and opioids, can really be caused by 3 different but overlapping manners. One is the direct toxic effects on organs and tissues. This is maximum in case of alcohol. Acute intoxication or overdose. Acute intoxication, people can indulge in risky behavior that can contribute to morbidity and mortality. Overdose, of course, is associated with risk of death, very high risk of overdose with opioids if they are injected, and dependence, addiction, loss of control, which leads to other kinds of morbidity and mortality. In fact, globally, whenever such exercises are conducted, when all psychoactive substances are ranked in terms of the harms they can cause to users as well as harm they can cause to others, multiple such studies have demonstrated that alcohol and heroin, which is an opioid, happen to be one of the most harmful substances known to mankind and are being used by mankind. So this actually underscores the importance of alcohol and opioid use disorders in terms of clinical practice as well. So as far as the clinical importance goes, there is high prevalence in the community that we have seen for alcohol almost everywhere in India, except for a very few small pockets. And opioids, particularly the entire North Indian belt, starting from northwest from Punjab to extreme northeast, is affected by a severe opioid use epidemic predominated by heroin use. In the clinic population, everywhere, if people know that alcohol use disorder treatment is available, they will flock to you. So in other words, the prevalence of alcohol use disorders in our patient population is likely to be high. This is more true for opioids, but then in case of opioids, it would also depend upon whether the right kinds of resources, which means the human resources, the knowledge, skills, and attitude of the health professionals, as well as the right kinds of pharmaceutical treatments are available at a particular clinic. So you can see actually doctors claiming that we hardly see any opioid dependence while they are sitting in the midst of raging opioid epidemic around them, because the patients know that this doctor doesn't treat properly patients properly. So in order for opioid dependent patients to come to you, you need to possess the right kind of knowledge, skills, attitude, as well as the resource. This is something very important for treatment of opioid dependence. Before going to specific treatments, let's go through some of the basic principles underlying treatment of all kinds of substance use disorders. What we need to remember is Number one, for substance use disorders, the treatment approach is supposed to be multimodal, which means there is importance of pharmacological treatment, there is importance of psychological treatment, there is importance of social support kind of interventions. So all three of them, when combined, they result in best outcome. However, we must remember that pharmacotherapy offers the mainstay of treatment. So all those misconceptions in the society that only counseling, only rehabilitation is enough, only motivation is enough, that simply is not true. We're talking of chronic non-communicable diseases just like diabetes, hypertension, and all of these require pharmacotherapy as well as psychosocial interventions and lifestyle modifications. Another important principle is offering the patients a menu of options, which means complete abstinence need not be the goal of treatment the moment patient steps in for the first time in our clinic. So in the first instance of meeting with the patient, if our only solution we are offering is complete lifelong abstinence from this substance that you are dependent upon, that may appear as unachievable for many patients. So in a graded manner, we can offer patients a variety of options and then help the patient choose among them. Overlapping to this as another principle that at different stages of treatment, the treatment goals are different. For the first few days, in fact, just remaining in treatment and coming to me next week would be a worthwhile goal of treatment. 1 year down the line, perhaps a better treatment goal would be whether you are completely maintaining abstinence or not, whether you have opened your bank account or not. So in other words, the assessment, monitoring, shifting of goalpost, that continues throughout the process of treatment. And again, an overlapping idea to remember here would be that duration of treatment needs to be adequate. So this, we are talking about chronic diseases which require long-term treatment. So adequate duration of treatment and engagement of patient in that treatment is very, very crucial. In this process, many patients would slip. Many patients would stop coming to us. Many patients would relapse and again start taking drugs. This need not be a disheartening event, either for us or for our patients. So relapses, entry into treatment again, trying to get back on treatment and achieving abstinence again is an inherent part of recovery. That's something we must remember. That's something we must explain to our patients as well. And to achieve all this, active involvement of patients in our treatment is very, very crucial. Side by side, since our patients are likely to suffer from many other illnesses, diseases, health conditions, those must also be addressed. So these are some of the general principles of substance use disorders. And if we talk of a general schema of treatment of all substance use disorders, and most importantly for alcohol and opioids, it would begin with the thorough assessment of the patients, followed by the short-term treatment in which we offer the treatment of withdrawal symptoms, a process which is also known as detoxification, which is actually a medical misnomer. And this must be followed in almost every case by a long-term treatment, which is primarily aimed at relapse prevention as well as rehabilitation and reintegration into the society. That's the general scheme which is followed for almost all patients of alcohol and opioid dependence. So considering the time is short, considering that we are all medical professionals, and considering that it's the pharmacotherapy which is the mainstay of treatment, I'm going to focus today largely on the pharmacological treatment. The question is, how does pharmacotherapy help? And this is something many of the people in the general community would also ask. Is there a magic bullet available which can help someone stop taking drugs completely? For this, we need to understand the entire cycle of addiction. Basically, in the initial phases, whenever people use psychoactive substances, which are essentially pleasure givers, they use them not for the purpose of with the aim of developing addiction. They use them because they feel happy, they feel nice, or they feel less miserable after taking them. But the acute phase, acute intake may result in toxicity or overdose, which is not a very common occurrence, but more often it results in euphoria, intoxication, some kind of positive experiences, as well as which lead to craving or desire for repeated use. The cycle continues, and ultimately, because of the sheer pharmacological properties of the substance, patient starts experiencing tolerance and withdrawal, which again forces them to continue treatment the substance again. And that's how the cycle continues. And that's the stage where various kinds of harmful consequences also appear, and yet the person loses the control, loses their ability to control use of these psychoactive substances. That's the central pathology in dependence. And that's how this cycle continues. So in other words, if we were to help this individual not use substances, we need to break this cycle. So pharmacotherapy, our treatment essentially seeks to break this cycle of someone who is forced to using these substances because of various reasons. How can there some medicines be taken which can alter or address some of these aspects in this cycle? For instance, if you were to use medicines which are effectively treating withdrawal symptoms, the contribution of these distressing, painful withdrawal symptoms in the need to take the substance repeatedly, that goes down. It helps the individual stop taking the substance. People use these substances because of they are unable to control their craving. If their craving is addressed, perhaps they will be able to stop it. There may be medications which simply block the effect of the drugs from achieving any kind of euphoria or intoxication. Those may be helpful. And there are some medicines, and we will come to them, which can act in multiple ways and help people achieve abstinence from these substances. So essentially, we are going to talk for both these substances, as I talked about that schema earlier, for both alcohol and opioids, the short-term treatment in the form of detoxification and the long-term treatment in the form of relapse prevention. Coming to the alcohol withdrawal and its management. Basically, alcohol is a general CNS depressant. Withdrawal symptoms whenever an alcohol dependent person is not consuming alcohol are likely to be symptoms of CNS hyperexcitation. So since alcohol causes you calmness of mind, helps you go to sleep, in the withdrawals, the alcohol dependent person would experience restless, anxiety, irritability, and agitation, difficulty in sleep. There may be symptoms of autonomic hyperactivity. There may be some gastrointestinal symptoms as well. Out of all these symptoms, tremor is something very specific for alcohol dependence. So a person who consumes alcohol almost every day and complains that I experience tremor if I am not drinking, that's almost a pathognomic sign of alcohol dependence. The physiological dependence has set in, that means. Most of the time, we find symptoms which are written in the black font here, but sometimes in 10 to 15% of cases, we can also find people affected by severe alcohol withdrawals in the form of seizures, disorientation, hallucination, a situation which is known as delirium tremens. Very shortly, we will come to that as well. As far as the time course goes, as soon as the alcohol dependence person stops taking alcohol, within few hours, they start experiencing withdrawal symptoms. The simple withdrawal symptoms achieve their peak between second to third day. And this is the period, in fact, in a minority of cases, but there is greatest risk of seizures. If untreated, within 7 to 8 days, these withdrawal symptoms are likely to come down. But in a small minority of cases, people may also go from third day onwards into the state which is known as delirium tremens, where there is risk of disorientation, hallucinations, and other kinds of psychotic symptoms, which really is a medical emergency, and we will come to that. So how to manage alcohol withdrawals? Again, a misconception in the society, among some of the colleagues as well, that it essentially requires admission to a so-called de-addiction center. This is a myth. The fact is, most of the patients of alcohol withdrawal can very well be managed on an outpatient basis, particularly those affected by mild to moderate dependence who have good social support as well. There may be some patients, a minority only, who are in severe dependence, who have past history of severe withdrawals, who have some other kinds of comorbidities, or who are on the extremes of their lives, pregnancy, those who have some other social kind of reasons for which they cannot stay at home and achieve abstinence. These are the kind of patients who would require hospitalization. For those patients and hospital who are hospitalized, clinicians can also use a systematic scale, goes by the acronym of SIVA, which can help in rating the severity of alcohol withdrawals and help in clinical decision making in terms of what kind of treatment would be required. So those in the moderate range, they would require pharmacological treatment and can be treated in outpatient. Those in the severe would, many of them would require pharmacological treatment in an inpatient setting only. So as I was saying, most patients are likely to be of moderate alcohol withdrawal who would be helped with just some supportive care, general supportive care, taking rest, being confined to their bed, not driving. Essential aspect would be pharmacological treatment in the form of benzodiazepines as well as vitamins, and I will come to some more details of this very shortly, and other non-pharmacological interventions in the form of counseling, motivation enhancement, just general support. That would be enough for many of these patients. It will be essential to prepare them for follow-up visits and long-term treatment. So how do we use benzodiazepines for the treatment of alcohol withdrawal symptoms? As I was saying, alcohol is a general brain depressant. If people who are alcohol dependent, they don't get alcohol, they are in a state of CNS hyperexcitability. We use benzodiazepines, which act on the GABA system to mimic some of the effects of alcohol, but in a much safer manner. And more importantly, it prevents CNS hyperexcitation from increasing and thereby preventing some of the complications of alcohol withdrawal. So that's how benzodiazepines help in it. But the idea is that benzodiazepines are supposed to be used only for short term, only for that duration by which alcohol withdrawal symptoms are likely to subside. Different kinds of regimen have been described. There is a fixed dose regime, which says that you decide a fixed daily dose of benzodiazepine and administer it in 3, 4, or 6 daily divided doses. The general rule of thumb is about 2 milligram of diazepam equivalents for every standard drink consumed. It requires careful monitoring of withdrawal symptoms. Must be started only when patient is out of alcohol intoxication and active withdrawal symptoms have set in. This would require to be treated just for about 5 to 10 days only, and by which it should be tapered. And as I was saying, benzodiazepines are supposed to be the treatment of choice for alcohol withdrawals, mainly because it relieves withdrawal symptoms as well as it prevents other complications of alcohol withdrawal in the form of seizures and delirium tremens. Which benzodiazepines? All benzodiazepines are effective. So you need not wait for a particular benzodiazepine to be available if another agent is available and which can be used. However, in general, the guidelines all stress that longer acting benzodiazepines are most suitable and most preferable. So the classic benzodiazepine, which is most common, perhaps the cheapest, perhaps the easily available, happens to be diazepam, which can be very safely used. Chlordiazepam is other benzodiazepine, which is slightly less potent than diazepam. It was actually marketed as something very specific to alcohol withdrawal treatment. How lorazepam is a relatively potent and shorter acting benzodiazepine. But one advantage which lorazepam offers is that it is not metabolized in liver and hence liver safe. Now, many of our patients of alcohol dependence, they are likely to, or many of them actually are suffering from alcohol liver disease. So in those cases, when we have some suspicion or we have a confirmation of impaired liver functions, lorazepam is supposed to be the preferred choice. How something the fixed dose regimen looks like. So 10 to 20 milligram diazepam every 6 hours orally you give on first day, then gradually reduce the frequency and dose over next 5-6 days, and it is expected that by 6th day your need of benzodiazepines will be gone and you will be able to totally stop it. So you can use diazepam chlordiazepoxide, depending on its potency, and the dose will be higher, or lorazepam. In such cases, remember that for lorazepam, more frequent administration will be required because of its shorter duration of action. But in all of these, we must provide patients parenteral thiamine for the first 5 days of treatment. Now, thiamine can be given orally also. All B complex vitamins can be given orally also. But in many patients of alcohol dependence, because of chronic alcohol use, the absorption of vitamins from the gut that goes down. So it's important that we replenish the depleted stocks of multivitamins, particularly of B1 group in the of the B group by using parenteral route. And thereafter, after 5 days, patients can be shifted on an oral medication of oral preparation of thiamine. If we are using benzodiazepines, particularly in the outpatient setting, we must warn the patients about the potential risks. Don't drive, don't drink in combination with benzodiazepine. Avoid those situations if you are suffering from sedation, which can meet in which you can meet with accident. It's very important. The fourth line: cease benzodiazepine if drinking resumes. Now, in outpatient treatment, it's sometimes very common that we prescribe a treatment to the patients and family members. Patient on third or fourth day is not able to maintain abstinence and drinks, but the family members think that the medicine has been prescribed to stop taking alcohol. So on top of alcohol consumption, when the patient is intoxicated, they may try to administer benzodiazepines. So that psychoeducation is very important at the outpatient prescription stage itself, that if patient has consumed alcohol, please avoid the next dose of benzodiazepine. This must be given only for a very short-term use only. That understanding is very important for the patients. As I was saying, parenteral thiamine is absolutely crucial part of treatment of alcohol withdrawals along with benzodiazepines, because this treatment acts as a prophylaxis, a prevention for other complications like Wernicke-Korsakoff syndrome. Initial few days intramuscularly, parenteral route, and then thereafter it can be given orally. If patient requires IV solutions of glucose or dextrose, we must give thiamine before administration of any such carbohydrate. For some other medications which may be used but not really essential, symptomatic management of pain, paracetamol, nausea, vomiting, metoclopramide, these kind of medicines may be used. But for most patients, simple combination of benzodiazepines and thiamine would do the trick. Some red flags. In this process, if we encounter seizures, delirium, or psychotic symptoms, we are actually talking of a situation known as delirium tremens, where all the other features of alcohol withdrawal are present, such as tremor, anxiety, restlessness, etc., along with delirium, which can manifest as disturbance in consciousness, disorientation to time, place, and person, many kinds of perceptual disturbances, including illusions and hallucinations. So typically, what are known as Lilliputian hallucinations, finding insects, spiders, snakes, lizards around them is what patients typically describe. Agitation. So this is a serious medical emergency. This requires treatment essentially in an inpatient setting, and that kind of inpatient setting which has the capacity to deal with patients of this kind. The good part is that the treatment of delirium tremens also is not substantially different from treatment of simple alcohol withdrawal. Here also, you just monitor the patients more carefully, but provide them more than the usual doses of benzodiazepines as well as IV thiamine at a slightly higher dose. Must remember that controlling agitations is important, and hence we should not hesitate to use higher doses of benzodiazepines also if we are certain that we are dealing with alcohol dependence and withdrawal delirium tremens. Must remember that the liver status here of the patients. So if patients have liver damage, then IV diazepam injection diazepam may be a problematic issue, and hence in those cases injectable lorazepam is something more preferable. only for very severe agitation, there may be role of low dose of injectable antipsychotics like haloperidol. So regimens for both diazepam and lorazepam have been described. Again, as I was saying, the idea here is to control the symptoms. So as frequent and as high dose as needed for control the agitation must be administered to the patient. This must be administered for next 3-4 days to maximum 1 week. It can be tapered. When the oral intake improves, patients can be shifted to oral thiamine as well. But after that, it's very important that we offer the patients long-term treatment as well as psychoeducation about further risk of delirium tremens, because one episode of delirium tremens increases the risk of developing delirium tremens in next episodes of alcohol withdrawals. A small quiz time. So you are in a setup where you are running a clinic, and the administration says that only one of these sets of medicines you can procure for managing alcohol withdrawal. Which of these would you choose? There are 4 options: A, B, C, and D. You may respond by chat. Which one would you prefer? So A is tablet diazepam, disulfiram, and B complex, capsules of B complex. B is, I'm sorry. Diazepam, lorazepam, and thiamine. C is injection diazepam, dextrose, tablet lorazepam. D is diazepam, disulfiram, and naltrexone. Okay, I can see responses. Very good, very good. So many of you have written B, and all of those who have written B are absolutely correct, right? We are talking of alcohol withdrawal treatment in an outpatient setting clinic here. So most useful for us would be tablet lorazepam, tablet diazepam, and tablet thiamine. Others are useful, but for other kinds of indications and other kinds of settings, which we will come to very soon. So this was about management of alcohol withdrawal. But as I was saying, relapse is almost a given. More than 60-80% of patients of alcohol dependence are likely to relapse after achieving abstinence after one episode of medically properly managed detoxification within next 12 months. So almost all patients would require long-term management of alcohol dependence. And after short-term management, what is known as detoxification, this long-term management is geared at prevention of relapse as well as improving functioning. And for this, there are 2 types of pharmacological approaches known. One is the deterrent approach of disulfiram. Another is using anti-craving medications such as acamprosate or naltrexone. We'll discuss both of them, these approaches. So coming to disulfiram, basically the concept here is that this medicine disulfiram alters the body's response to alcohol. So if you are taking disulfiram and on top of it you drink, you develop some unpleasant or toxic kind of experiences. It's the fear of these symptoms which helps you stay away from alcohol. Many clinicians, many old-time books and publications also mistakenly describe disulfiram as an aversive agent, as if the idea of treatment is that patient should take disulfiram, patient should drink, should experience the unpleasant disulfiram alcohol reaction, and then as a result of that unpleasant experience, patient will stop using using alcohol further. That's not true. Disulfiram is not given to a patient as a punishment for drinking. It's given with the full knowledge and consent that you should not drink. It increases patient's resolve or motivation to stay away. How does it help? It basically interferes with alcohol metabolism. It inhibits this enzyme known as aldehyde dehydrogenase, which results in accumulation of aldehyde if people drink on top of disulfiram. And this reaction can occur up to 2 weeks after the last dose of disulfiram. This is a schematic presentation here. In normal course, alcohol gets metabolized into acetaldehyde, which gets further metabolized as acetate, which is excreted from the body. Disulfiram inhibits the second enzyme, aldehyde dehydrogenase. So if you drink, acetaldehyde will get accumulated, which will result in what is known as disulfiram ethanol reaction. Begins very soon after drinking. It's really more unpleasant than dangerous. But in a small minority of cases, it can be potentially fatal as well. It can be life-threatening as well. More the amount of alcohol consumed, more is likely to be the severity of reaction. So these are the kind of symptoms which one often finds. Symptoms typically of autonomic instability, warmth and flushing on upper chest and face, severe nausea, vomiting, headache, weakness, giddiness. All these kind of symptoms can occur, which are very, very unpleasant for the patient. So again, I will once again reiterate this point, that the idea here is that these symptoms are described to the patient, and then patients are made to understand that if they take disulfiram, they should not drink. So that's the reason why disulfiram is an appropriate medication only for those patients who are abstinent and who plan to continue to remain abstinent, who are motivated to maintain their abstinence and to fully understand and would remember that, yes, I have taken disulfiram today. So the question would arise to anyone's mind that if that is the case, if the patient is already motivated to take disulfiram, then what's the need of taking this disulfiram if the patient is already motivated to remain abstinence? The answer here is, and many patients in fact ask us in clinical practice, Dr. Saab, when I have already decided that I'm not going to drink, then why are you prescribing this medicine to me? The idea here is patients must understand that the strong motivation they are experiencing today may not remain at the same level 3 months, 6 months down the line. There may come a period after 3-4 months when they would believe that, okay, now they have achieved victory over their desire to drink. Now they have regained their control. They are just going to drink once on that particular party, and from next day they are not going to drink at all. But as many patients earlier experience would tell them that if they take even one drink, it will lead to another, then third, and from next day they find that they have relapsed to drinking again. So disulfiram helps in maintaining their motivation because of fear of disulfiram ethanol reaction. Also, since peer pressure is an important factor in relapse in many cases, where friends tell you, oh, you have been abstinent for 4 months, just take one beer, nothing happens. So if patients are taking this medicine, they will be able to resist their peer pressure by telling, no, I am on a medication. If I drink, it may lead to very severe reaction. So that's how it would help many patients. And that's how, surprisingly, contrary to what the Western literature says, clinical experience suggests that many patients in India, after good psychosocial interventions and psychoeducation, agree to take disulfiram. Important point here is the informed consent. We must take a written informed consent from the patients who are agreeing to take disulfiram. Treatment is really simple. Just one tablet of 250 milligram to be taken once a day, usually in the morning after breakfast. But if patients experience some sedation, they can take in the evening as well. In some patients, a higher dose may be required. If they miss, nothing to worry about. They can take as soon as they remember. They should avoid taking double dose in case they have missed for 2 or 3 days consecutively. So this was about disulfiram. I'll now come to another approach for treatment of alcohol dependence, which is anti-craving approach. There are some medicines who do not interact with alcohol at all, but they somehow interfere with the way alcohol reinforcement and desire that takes place in the brain. So there is a medication called acamprosate. The one important feature of acamprosate is its very, very poor oral bioavailability. And for some reasons, they have still not been able to formulate a good sustained release kind of preparations for acamprosate. the highlight or the very useful aspect of acamprosate is that it does not get metabolized into liver. So it's hepatic safe. So even if patient is actively drinking and has suspected or confirmed liver dysfunction, acamprosate can be used in such patients. This makes it very useful in clinical practice for many patients. It is available as a oral tablets of 333 milligram, but and that's the reason why the dosing regimen is very complicated. So you have to take 2 tablets in the morning, 2 in the afternoon, 2 at night to make the dose around 1998 milligram every day, which is a really complicated regimen for anyone to comply with. Imagine taking for 6 months at a stretch 2 tablets in the morning, 2 in the afternoon, and 2 at night. It would be really difficult to comply with this kind of regimen. But many patients who take it, they find it useful, particularly for those patients who are likely to experience Q-related craving. So patients are abstinent, but they say whenever I pass through in front of that alcohol shop, or I find I find my friend or that spot where I used to drink earlier, I again experience craving. For those patients, the acamprosate can be useful. Another anti-craving medication known is naltrexone, which is really an opioid receptor antagonist. Now, the important point to understand here is some of the reinforcing and euphoric aspects of alcohol are mediated through the opioid system. So naltrexone, which is really an opioid receptor blocker, it blocks that kind of euphoria or pleasure associated with alcohol consumption and thereby reduces the desire to drink. So some patients on naltrexone, they say that if I drink, I achieve satiety or satisfaction very early. Earlier, when I was drinking actively, I used to take one drink, then second, then third. With naltrexone, even after one drink, I sometimes feel like, oh, it's enough. I need not drink more. So that's how it reduces the rates as well as severity of relapse. Very simple treatment again, 50 milligram, 1 tablet to be taken orally. Problem is it's metabolized in liver. So it's not really a very good treatment for those who already have liver dysfunction. In clinical practice, what can also be done is combination of both disulfiram and acamprosate, or disulfiram and naltrexone if the liver functions are fine. The questions may arise that if patient is already motivated to remain abstinent and taking disulfiram, what is the need of using anti-craving agents? Two reasons. One is in many patients, craving can lead to desire to drink, and that's why those patients can then, because of that craving, consciously take a decision to stop taking disulfiram also, and because of their craving, they can again consume alcohol and relapse. For those patients, a combination of disulfiram and an anti-craving agent that may help. Another important feature which many professionals do not realize is craving itself is a distressing symptom. So just like pain, anxiety, these are distressing symptoms. Craving is also a distressing symptom. So if the patient is affected by craving, even if they are living in a situation where no alcohol is available, such as a jail or such as a completely alcoholic or prohibition kind of surrounding where alcohol is not available, but if they are affected by craving, then it's worthwhile to provide anti-craving to reduce their distress. Some other kinds of anti-craving medications are also available: baclofen, ondansetron, SSRIs, lamotrigine, etc. But really in clinical practice, particularly in our center in NDDTC, the two most commonly used anti-craving agents are naltrexone and acamprosate. Again, a quiz time. What do you think is the answer here? You can respond by chat. One of these statements is incorrect. Okay, okay, okay. I can see. Yeah, I know the answer appears to be very obvious to everyone. Many people would think that why such a easy question has been asked. The point is that there comes a time, even in the life of many experienced clinicians, when they feel like doing something. Typically, a patient's wife comes to the clinic and begs to the doctor, "Doctor, please do something. My husband is drinking continuously, beating me, not listening to me. Just give me something so that I can mix in his food and help me." So the idea of doing something good for the society may sometimes make the clinician take such silly decision. What we must remember is that we are clinicians in aid of primarily our patients. So our patients are our index clients. Those are the people we are likely to serve. If we help our patients and indirectly their family members get helped, that's a bonus. But primarily we are there to help our patients. So unless a patient explicitly gives us their consent, no question of giving them disulfiram. So that completes our alcohol part. I know that that there are many things which we could have discussed, but since there is shortage of time, I'll go to opioids. Now, opioids are a wonderful products. The opium poppy plant is a very powerful, very well-known euphoriant as well as analgesics. And that's why in various forms, opium and its products have been literally been used for thousands of years, both as recreational substances because of euphoria and as medical products because of their analgesic properties. So afim or doda, fukki, the poppy husk, they are examples of natural opiates. As a semi-synthetic product, one of the most common and as I said earlier, the most harmful illegal substance known happens to be heroin, which again in India is available as brown sugar or pure heroin. Chitta is the name it is called by in Punjab. There are pharmaceuticals which are primarily used as analgesics. So injections of buprenorphine and pentazocine, very commonly used in clinical practice, and or some of the tablets which are used as painkiller or even as for the treatment of diarrhea as well, like tramadol. Now, whenever opioid dependent patients present in the outpatient clinics, they offer some differences as compared to alcohol. For instance, in alcohol dependent patients, we often find some kind of denial and minimization. So their family members would say he drinks heavily, but patients would typically claim, no, 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 I drink in control. I have total control on my drink. I don't drink very frequently. That's not the case with opioid dependence. In fact, if at all, if opioid dependent patients know that you are going to give them medicines corresponding to the amount they are taking, they are likely to boast of or inflate the amount of heroin or other opioids that they are using. Since many opioids happen to be illegal, we often find some history of involvement with law enforcement or criminal justice system. In many patients, particularly women or some young people also, opioid dependence will be iatrogenic in origin. So because of pain or some other physical problems, they were prescribed opioids. They started opioids as treatment, but then they became dependent. They developed dependence on it. We can also find consequences, physical consequences of opioid dependence, like blood-borne viral infections, HIV, or hepatitis C. In fact, hepatitis C among people who inject drugs is excruciatingly common. Opioid withdrawals are very distressing clinical conditions. So just like the picture seen here and the symptoms written here, patient really can believe that they are going through a hell while they are experiencing acute opioid withdrawal. So alcohol withdrawals are also distressing, but opioid withdrawals are much more painful and distressing. Though alcohol withdrawals less distressing, but untreated, alcohol withdrawals are potentially fatal. As I was saying, a minority of patients may develop seizures or delirium tremens in case of untreated alcohol withdrawal. That risk of meeting a fatality is very rare in case of alcohol withdrawal, though they are very, very severe. However, the important thing to note here is these severe distressing alcohol withdrawals, even in case of short acting opioids like heroin, would be experienced only for a few days. Typically, in case of heroin, acute alcohol withdrawal would achieve their peak at around third to fourth day. Thereafter, they will start coming down. And it is expected by 7 to 10 days, maximum 2 weeks, you will experience a total baseline kind of effect
कॉफी
from
दे दो
acute opioid
गरम
withdrawals. However,
आधा कप
at the end of that 10 days to 2 week period, when the acute opioid withdrawals are subsided, it's not the end of the story, because most patients would continue to experience mild but distressing enough opioid withdrawals for many weeks to even up to 6 months. So some degree of pain, disturbed sleep, poor appetite, psychosocial dysfunction in men, they are likely to remain for many weeks to months, and this becomes a very important reason for relapse. This makes opioid dependence classically a chronic, non-communicable relapsing disorder. Since opioid withdrawals, as I was saying, are distressing, they need to be treated. Just like alcohol dependence, most patients of opioid dependence also can be treated in the outpatient setting for their treatment of withdrawal symptoms. So mild to moderate dependence, good psychosocial support, living very close to the clinic, you can treat them at outpatient. What is listed here, these are some of the indications for inpatient treatment. Obviously, more severity, more comorbidity, other psychosocial problems, they would require inpatient treatment. But that again, in clinical practice, only a few patients would require. Pharmacological options for treatment of acute opioid withdrawal happens to be, the gold standard happens to be use of agonist medications. Opioid group medications like buprenorphine or methadone, they are the agents of choice. I would say they are the only agents to be used. There are advocates of non-opioid medications like clonidine as well, which can take care of some symptoms. Till few years back, it was very common. Now it's rarer, but still takes place. I know what is known as UROD, or ultra rapid opioid detoxification. Use of general anesthesia actually to precipitate severe opioid withdrawal, and then help the patient come out of that opioid withdrawal phase very quickly. This is not just ineffective, it can be dangerous as well. So that's why we would recommend only using agonist medications as gold standard for treatment of acute opioid withdrawal. Buprenorphine happens to be the most suitable medication for that purpose. Can very well be used in outpatient and inpatient setting. There are some unique pharmacological properties of buprenorphine. One is that it is a partial agonist on opioid receptors with a ceiling effect. So by ceiling effect, what one means is, even if a patient deliberately or accidentally takes an excessively high dose of sublingual buprenorphine, there is unlikely to be any harm. Important thing is it has a very high affinity to opioid receptors, even as compared to heroin. So if the patient decides to use heroin on top of pure buprenorphine, there is unlikely to be any effect, because buprenorphine has higher affinity to opioid receptors. Buprenorphine would have already occupied those receptors, and heroin will not be able to act. On the contrary, if patient has taken heroin, and if they have taken buprenorphine on top of it, because of higher affinity, the partial agonist buprenorphine will displace the full agonist heroin from the opioid receptors. That will lead to precipitated withdrawal. So one big clinical understanding from here is that the first dose of buprenorphine, sublingual buprenorphine, must be taken only when there is a gap of at least 4 to 6 hours since the last dose of heroin, because by then the opioid receptors will not be occupied by heroin. This is what we do in outpatient treatment. We give buprenorphine in typically in 3 divided doses, but in relatively smaller doses. So the prescription would look something like this: 0.4 milligram buprenorphine, 3 in the morning, 3 in the afternoon, 4 at night. As an adjuvant, we can use diazepam or nitrazepam up to 10 to 20 milligram also for sleep if necessary. So the idea here is that we give them in short burst of prescriptions of 3-4 days, and within next few days to weeks, we then taper this off and bring this to 0. In every outpatient visit, we need to ask about these things on the follow-up. And the clinician should be able to treat this condition with an open mind. If it feels like that your dose which you are using is not enough, the dose can be increased as well. If you think that patient requires a slow taper, then you can prolong the duration of this treatment as well. In other words, a slightly liberal attitude helps many patients take this treatment adequately, improves treatment compliance and retention, and helps them get off from opioids. So as I was saying, we should be prepared for slow taper, and hence this taper may require up from 6 to 12 weeks. Contrast this with the time period I was describing for the duration of acute opioid withdrawal, just about 2 weeks. So if you are doing this treatment in the inpatient setting, perhaps by within 2 to almost 3 weeks, you should be able to taper buprenorphine, the agonist, completely. But in outpatient setting, because of various reasons, patients would require a much longer period to be able to stop their agonist medications completely. What about other treatments? If buprenorphine is not available readily, or you have some concerns about giving buprenorphine, and I'll come to those concerns, tramadol also can be used, about 6 to 8 tablets of 50 milligram per day, which is a poorer alternative to buprenorphine really. There may be role of other medicines such as benzodiazepines as adjuvants, NSAIDs for pain, etc., or some other kinds of symptomatic treatment for vomiting or diarrhea, etc. But the gold standard of treatment of acute opioid withdrawal happens to be opioid agonists like buprenorphine. After you have stopped and tapered your buprenorphine completely, what happens then? We must remember this is not the complete treatment, because relapse is rule rather than exception for a large, overwhelming majority of opioid dependent patients. More importantly, there is significant risk of mortality from overdose after detoxification. Why? Because patients have lost tolerance to opioids. Earlier, they were, say, injecting about 1 gram of heroin every day because they had tolerance to that dose of heroin. Now that you have provided them treatment of their withdrawal symptoms, they have lost that tolerance. If they relapse after a few weeks of treatment and they believe that their dose still is 1 gram of heroin, they would inject that, their body would perceive as much higher than they are tolerant to, and they can do overdose. Research has actually demonstrated this, that patients who have successfully completed inpatient detoxification, they are more likely to die as a result of overdose when they relapsed. A very quick quiz question. Responses welcome on the chat. Ayushi, you may want to read once again very carefully. Yeah, I can see. Okay, so let me describe this. All the following are true for buprenorphine, except does buprenorphine has high affinity for mu receptors? Absolutely. I told you it has the highest affinity among all opioids. So between heroin and buprenorphine, if there is a competition for who will occupy the opioid receptors, it is buprenorphine. Does it have high intrinsic activity of the receptors? No. It binds receptors very tightly, but it doesn't do much after sitting on those receptors. So intrinsic activity of buprenorphine is lower as compared to heroin or many other short-acting powerful euphoriants. That's the reason, that's the beauty of buprenorphine, in fact. It sticks to the receptors, but doesn't lead to much of the opioid effects in terms of intoxication or euphoria. That's why it is much less addictive as compared to many other opioids. A long duration of action, of course, is a very recognizable, very important feature of buprenorphine, and it provides good relief from withdrawal and craving. So correct answer here would be B. So let's proceed then. As I was saying, since the short-term treatment detoxification is not the complete treatment, and ideally must always be followed by long-term management. For the long-term management, we have again two approaches in the form of agonist treatment, which also goes by the name of OST or opioid substitution treatment, and the another very different approach, antagonist treatment. So what is this treatment, OST or opioid substitution treatment? Basically, our patient is taking a drug like heroin, which is a short-acting illegal drug, very unsafe, taken by injecting route. And since it's short-acting, it has to be taken multiple times a day. What if you do something and substitute on their opioid receptors heroin with another agent such as buprenorphine, which happens to be a legal, safe, long-acting medicine given by a very safe route under medical supervision. Since it's long-acting, it has to be taken only once a day. So what happens here is that particular patient's life, which was earlier the chaotic lifestyle of an of a opioid dependent person, or as they call them, addict or a criminal. Now he has the status of a patient. His opioid requirements are filled by a legal, safe, in most cases, a free of cost medicine, which has to be taken only once a day. Now patient has all the time and opportunity to look after their other responsibilities in their life. So we must remember here that in this term, opioid substitution treatment, it is at the receptor level, one opioid which has been substituted by another, much safer opioid. This is not in patient's life, one addiction which has been substituted by another addiction. And this is a misconception all of us need to fight tooth and nail. Not just our patients, not just family members, not just community, even our fellow professionals, medical professionals, as well as administrators. In many hospitals, people would claim that our medical superintendents or their deans and directors, they say, what are you doing? You are just giving them one addiction in place of another addiction. So that misconception needs to be treated. There are many people who require treatment, who require medicines for replacing their thyroid hormones. There are many patients who require insulin, many patients who require antihypertensive or hypoglycemic medications. Similarly, there are patients who would require opioid agonists, which are safer alternatives, but which would help them stay away from illegal opioids and helps them being more productive. So what's really the big deal here? The big deal here is the duration of action. If a patient is taking heroin, that means they have to take it 3 or 4 times a day because it's a short-acting drug. So that's why maximum time of the day, patients would experience either in the phases of intoxication or high, or in the phases of withdrawal. And in both these situations, patients will really not be productive. So their whole life revolves around just taking their next fix of heroin, and they are unable to do anything more worthwhile. If they are taking an agonist medicine like buprenorphine, which doesn't lead to much intoxication, doesn't lead to much withdrawal, and hence to be taken only once a day. So maximum time, the 24-hour time patient spends in a more comfortable, more productive phase where they are free to look after other things. So that's the beauty of this treatment, and that's the reason why it helps so many patients. One of the some of the criteria. Sorry, I believe I was disconnected for a while. Am I audible now?
Yes, sir.
Thank you.
Yes, sir. Yes, sir. You are audible.
Right.
Please carry on.
Right. So we'll carry on from where we were interrupted. So In terms of the criteria for which patients can be given this, very simple. Patients must be suffering from opioid dependence, and they should be willing to follow whatever procedures and rules to be able to take this medicine every day and able to provide an informed consent. So this would really fit a large majority of patients, provided such a facility is available in their vicinity. There are some other criteria as well, which are not essential, but they help the confidence of the clinician in providing this treatment. Patients who are adults, patients who have been taking opioids for a very long time, as a result of their opioid dependence, if they have poor psychosocial functioning, poor support from the family, they have high risk behavior like injecting, have tried earlier but have failed achieving any abstinence. So if these features are also present, that helps us take the decision about suitability of this maintenance treatment. But really, the gold standard treatment, any guideline will tell you, happens to be opioid agonist treatment because of the very strong evidence base of its effectiveness. Treatment, since as I was saying, by definition, this is a long treatment. There are phases of this treatment. There is the initial phase, which begins from the first dose to the establishment of daily dose, which is known as the phase of induction. Once you have achieved what is the daily maintenance dose of the patient, that dose then continues for a very, very long time. How long, you would ask? No one knows. But definitely from many months to many years. In some cases, possibly lifelong also. This is the phase of maintenance, where patients are really maintained on one single daily dose, which then continues for a very long period of time. If and when you come at a point when you and patient both decide that, okay, enough, now we can stop taking this treatment, now we can get off this treatment, from that point to the last dose, when you are tapering the dose, that is the phase of termination. Right? So basically, as I was saying earlier, buprenorphine, high affinity receptors, so must provide it the dose only when the patient is in opioid withdrawals, at least 6 hours after the last dose of their heroin. We provide the first dose as 2 milligram sublingual tablet of buprenorphine. Observe, if required, we can give one more dose on the first day. We do this for next 3 to 7 days, basically to achieve what is their optimum daily dose. And how do we define that optimum daily dose? Talk to the patients. If they are saying, Dr. Saab, I was fine when I left your clinic, but by evening, I again started experiencing some craving or withdrawal, that means you need to increase your dose. Patients are under medicated. If patients say, I was sleepy, drowsy throughout the day, possibly they are over medicated. If patients are happy, they would say neither. I was fine with this dose. I neither experienced any craving or withdrawal or any desire to take opioids. That's the dose we need to achieve. And that's the no dose we need to maintain our patients. That optimum dose. Please remember here, the crucial term here is optimum dose, not lowest possible dose. Right? And what's the importance of that? I'll come to that very shortly. So this period needs to be continued for a very long period of time, where we need to ensure compliance. We need to monitor drug use. We need to also monitor for other kinds of effects, other kinds of issues, such as use of other drugs, as well as psychological occupational rehabilitation. Discontinuation only when we think the goals of treatments have been met. And as I was saying earlier, when I was discussing the principles of treatment, these goals may shift. If today a patient is entering treatment, the goal simply may be to stay away from heroin for next 6 months. Worthy enough goal. But 1 year down the line, if the patient has achieved abstinence, perhaps the goal may be a bank balance of 2 lakh rupees. After 2 years, perhaps the goal may be contribution to his sister's wedding financially. After 4 years, the goal may be to settling down in life, getting married, having kids, and so on. So till these all goals of treatment, which have been decided mutually by us and our patients, this treatment needs to continue. Now, buprenorphine is a wonderful medicine, wonderful drug. The only problem is if this can be taken sublingually, patients can inject it and then they can obtain some degree of pleasure. So that's the reason why this combination of buprenorphine naloxone has been introduced, where if it is taken sublingually, there is effect of only buprenorphine. But if patients are naughty and they try to inject these tablets, crush and inject them by dissolving them in water, there will be availability of naloxone also, which is an opioid antagonist. So it is expected that such a combination injected, it will either have no euphoria or there may be precipitation of withdrawals, not much reinforcement. So that will protect it from the risk of getting injected. In practice, however, in spite of availability of this combination of buprenorphine and naloxone, some patients do inject and find it pleasurable. So it does not offer absolute protection. It reduces the risk merely. So some degree of carefulness is vital, is important on the parts of clinician, so that indiscriminate dispensing of buprenorphine naloxone must be avoided. But in general, as take home, buprenorphine naloxone is suitable as opposed to the known as plain buprenorphine. This is what I was talking about when I was discussing optimum dose. On a relatively lower doses, like let's say for example, 2 to 4 milligram, many patients would say, yes, my body ache, my withdrawal symptoms are controlled now. But I still continue to experience some desire. I still remember taking heroin. I still remiss those days. So that means they still have craving. They would require a higher dose to control this craving. Even when their craving is controlled and withdrawals is controlled, that may not be regarded as optimum dose, because a slightly higher dose than required for control of craving would be required for opioid blockade effect. What is blockade effect? On my buprenorphine, if my patient decides to use heroin, patient should not be able to experience any kind of euphoria. That's the idea behind blocking effect of buprenorphine. So if your patient says on 8 milligram is the absolute dose on which I am not experiencing any craving, feel free to prescribe up to 10 milligram, because if 8 milligram is the good dose for control of craving, a higher dose will be required to achieve the blockade effect. And unfortunately, we find blockade effect only when patients inject some other opioid on top of our treatment. One question which is often asked, and which is I often see many clinicians do this in the maintenance phase, is a desire on the part of the clinician to unnecessarily reduce the dose. So whatever is this the optimum maintenance dose, that needs to be continued throughout the period of maintenance, unless the patients complain of side effects. Are there some situations in which dose needs to be increased? Yes. If patients are going through any stressful situation, if patients meet accident, are hurt, are experiencing some pain, because opioids are painkillers. If patients are engaged once again in menial kind of work, hard work, which leads to body ache, their opioid requirements may go up. Or because of some reasons, there is re-emergence of craving. Doctor, the neighbor with whom I used to take drugs has come back again. I look at him and I again start experiencing craving. That means that craving now needs to be addressed by perhaps increasing the dose of buprenorphine. How to decide when to stop? As I have said earlier, duration is not the criteria. It may be 1 year, 2 year, or even 5 years. And in my own follow-up, I have patients who are 10 or even 12 years on treatment, are doing quite well. Achieving abstinence is not the sole criteria. Attainment of treatment goals is the criteria. And as I was saying, the treatment goals may shift or need to shift, in fact, as the treatment goes on. So this was the one important and the gold standard approach for treatment of opioid dependence. I know the time is running, so I'll very shortly talk very briefly about the antagonist treatment in the form of naltrexone. We have already discussed naltrexone as an anti-craving agent, which is a pure agonist at mu opioid receptors. It doesn't do anything to opioid receptors actually. It just blocks them. It doesn't have any action of its own, rather than blocking the effect of other opioids if they are taken on top of naltrexone. So 50 milligram, just one tablet per day is the dose. If higher dose is used, it can offer protection for a longer period of time. But this treatment actually works best only with those with a lesser degree of severity of dependence as well as higher degree of mood. So people who have started opioids only recently, who have no other psychological or medical problem, who have good psychosocial support, who have the ability to withstand the craving as well as protracted opioid withdrawal symptoms. For them, naltrexone could be a good option. So educated, qualified, white collar professionals, these are the kind of patients, many healthcare professionals, these are the kind of patients for whom naltrexone may work very well. The people with sort of lower psychosocial status, socio-occupational status, doing menial labor, long duration of opioid dependence, they are not very good candidates for using naltrexone as an antagonist treatment. So what's the idea here? Just provide what is known as detoxification, which we have already discussed. Make sure that there are no traces of opioids left in the body. There are no opioid receptors occupied by any agonist, and then you can provide first dose of naltrexone. At least 3 to 7 days of opioid-free period is important to start this. Otherwise, patients will start experiencing precipitated withdrawal. So, in clinical practice, it's a good idea to conduct what is known as naloxone challenge test. Naloxone is injectable and very short-acting opioid. So if patients have some agonist medication, some agonist effects of opioids still there, you inject them with naloxone, they will experience withdrawal symptoms, but because it's short acting, those withdrawal symptoms will be subsided very soon. If there are no withdrawal symptoms, you can safely start naltrexone. Okay, I suppose this may be the final question for today, which I am asking. If you need, I'll explain this question. So there is this patient which is in the initial phase of treatment. You are in the induction phase of agonist maintenance treatment. Which of these is the least priority? Do you enhance their motivation? Do you address their other medical needs? Decide the total duration of treatment, because that's the part of our treatment goal. Or court hearing. Okay, I see some D, some C, some C, D, C appears to be okay, majority. Right. So I'll like to very quickly explain this. Basically, A, B, and D are very important parts of as initial phase of treatment. We must enhance their motivation. That's a given. If there is a medical crisis, we must address this in the initial days of treatment. Impending court hearing. Oh, impending court hearing may mean that patient may go to jail, or on that day, patient may not come for taking treatment. So it's a very essential part of discussion. How long this treatment will continue, that need not be specified in the initial days of treatment itself. For the first, when you are starting this treatment, just buying some time from the patient, that please give me a commitment that you are in this treatment for a long duration, for a few months. Let the few months to at least 1 year treatment go, and then we will decide whether the treatment needs to continue or not. So that's the idea here, that we do not decide a final date on the initial days of treatment itself. Okay, there is another question. What do you do for this gentleman who was doing well with this treatment for months, now started working? What do we do with those? Good. Thank you very much, everyone. So I can see many D's here, which is the right answer. So just the buttressing or reinforcing the same point that we need not feel shy of increasing the patient's dose because of change in their life situations. Dose reduction is not necessary. Dose increase may sometimes be considered when a patient meets any different life circumstances. So we're concluding here, both these alcohol and opioid dependence, chronic, relapsing, non-communicable diseases, just have the mindset of treating them like you would have for treating diabetes, hypertension, depression, bipolar affective disorder, or whatnot. Long-term treatment is essential to achieve good outcome. It's not just a good clinical practice. In this treatment, pharmacotherapy plays a major role along with psychosocial interventions. Unfortunately, because of the time constraints today, we could not discuss psychosocial interventions much, but they also play a very important and crucial role in the treatment. Mainstay happens to be pharmacotherapy. That's something we should not forget. So besides our clinical skills, our attitudes is also very important factor for success of this treatment. So throughout this process of treatment, we need to provide an empathetic, non-judgmental kind of care to our patients. A wide variety of resources are available online also free of cost for all of us. I'm just showing here the national level resources. There are international also, but there are quite a few practice guidelines and manuals developed by our professional societies as well as experts bodies constituted by the government. So feel free to access them for more information and expertise on this. Thank you very much, ladies and gentlemen, for your patient listening. I'll be very happy to engage further in discussion on this. I have deliberately kept some time for all of us to discuss this in more details. Thank you very much.
Thank you very much, sir, for such an interactive session. Like all the participants were very excited to answer, mainly for the MCQs, and it was pleasant to listen to you, sir. Uh, Sir, there are some questions which were put previously, like before the
Okay.
responses to the yes, sir. So I have just put it there. One
Right.
question, Mr. S. Jain.
Uh-huh.
Yes, sir. Can oral thiamine be given in initial days in outdoor management?
Right. Important question. Good question, and it can sort of affect many clinicians. There is nothing against that oral thiamine cannot be given. Good clinical practice means we must provide thiamine injectable because, as I was saying earlier, oral thiamine is not very well absorbed. We do not want our patients to suffer from thiamine deficiency and the resultant complications in withdrawal state. So there may be practical considerations, I understand. Patients, outpatients staying at home. What we do in such cases is just prescribe injections to them, and many patients in their vicinity, they can find any clinician or even a nursing staff who can inject them. So patients buy injections, patients buy syringes, go home and find someone in their neighborhood who can just provide them this injection. So that should take care of many of these concerns. Right.
Next question is from Baby Max. Sir, how to determine the maximum dose of diazepam or lorazepam which can be given in DT? I think
Right.
this.
So, yeah. Go ahead, Jaswant. You were saying something.
Yes, sir. I think this question was answered later on, like after this
Yeah.
question was asked.
Yeah. Yes.
Well,
Yes. So
it's a,
basically, it's nothing like an upper limit really, but this dose is determined by the severity of their delirium tremens, their delirium symptoms. Some patients do require an excessively high kind of dose, which would make many clinicians uncomfortable. So important thing to remember here is that we must, if we are think that we have to use high dose, then some higher degree of expertise needs to be available with us. So perhaps a high dependency unit kind of facilities, perhaps ICU in many private settings, this may be required. So for excessive high dose that can be required, but many delirium tremens patients, even with the doses which appear high in otherwise routine practice, are able to tolerate and respond very well. Right.
Next question is from Dr. Nileshwar.
Mhm.
That should we go up in the doses of oral or parental thiamine dose beyond 300 mg in case of uh, suspected
Yes, 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 yes.
WKS in
Got it. So as we saw in our presentation slides as well, the dose of thiamine is really higher if in case of suspected or actual delirium tremens and or Wernicke-Korsakoffs. So that's the given. Yes, we must be able to give higher doses of thiamine, and there are if there is suspected deficiency of other vitamins of B group, multivitamin kind of preparations can also be safely given.
Sir, apart from this, there is question from Usman Hotiana. Many times young patients come with polysubstance abuse with alcohol, cannabis, amphetamine. Under such unclear history and patient in gross psychosis, what safely starting regime could be followed, or is wise symptom based?
Okay, I got the question basically. So the yes, I understand that polysubstance abuse or even medical comorbidities sometimes complicate the clinical picture. But all said and done, if there is contribution of alcohol withdrawal to delirium tremens, patients would require treatment with benzodiazepines. Alcohol withdrawal delirium cannot be effectively treated with other kind of medications like antipsychotics. So if we are reasonably sure that we are dealing with a case of alcohol delirium tremens, alcohol withdrawal related delirium tremens, we can safely use benzodiazepines, even though there may be contribution of cannabis or amphetamines to complications of clinical picture. If there are other symptoms of psychotic symptoms which we think are resulting from cannabis, for those antipsychotics can be added. But if there is DT, that would require benzodiazepines certainly.
Yes, sir. Sir, one question is there from Dr. Anil. Is calling addiction as brain disease justified? How to measure severity of addiction without using any scale in busy OPD?
Right. So addiction as brain disease or not, I know there is a lot of debate here. Calling addiction a brain disease has helped reduce some of the stigma of addictions. Like in the opening session also, when our seniors were doing their opening remarks, they highlighted this fact that this is not just a bad habit we are talking about. This is an illness. This is a disorder. And to that extent, a disorder which is in which brain is the primary organ affected. So to that extent, brain disease is not really a wrong kind of term to be used, particularly in case of awareness building in the community. But if you want to really go threadbare and dissect this term further, that is primarily the brain which is diseased? Are we saying that people have already have a diseased brain and that's why they have developed addiction? What about human rights of people who want to just use substance recreationally? Then we are going into a different kind of territory. So that debate I suggest we leave right now. Suffice it to understand that we are talking of a biopsychosocial disorder here, in which there is contribution of biological, psychological, as well as social factors. About your question about measuring severity of addiction without any scale in busy OPD. See, scales really are not designed for deciding clinical practice. Primary purpose of this rating scales or severity scales is for research. So we should be able to determine the severity of addiction through good clinical interviews and decide our treatment plans accordingly. My suggestion would be just to develop good clinical kind of skills, and the point about busy OPD is fine, but I will not be very comfortable not talking to a patient in detail and basing my clinical decisions only on the basis of some scale scores which has been filled up by someone else, right? Because I know when I'm doing my clinical assessment, I'm also doing a kind of intervention in terms of, number one, engaging the patient with an empathic attitude, as well as perhaps using the opportunity to enhance their motivation. I do not really see a very good scale also replacing our clinical skills. With time and experience, of course, within a busy OPD also, it should be possible to determine enough level of severity to be able to base your important that day's clinical decision. I hope I have helped you, but I'm not sure.
Sir, there is one question asked on YouTube comments
Mhm.
that in a patient with alcohol dependence syndrome with multiple comorbidities with poor informants, how to differentiate between delirium tremens versus delirium secondary to medical illnesses?
Right, right. I understand, and this kind of dilemma may arise on many occasions. Some of the pointers are definite history of alcohol dependence and definite features of presence of alcohol withdrawal symptoms, other alcohol withdrawal symptoms. So tremors and other kinds of or symptoms of autonomic hyperactivity, if those are present, our sort of index of suspicion towards DT that goes higher. Similarly, if we are able to get prior history of delirium tremens, that indicates this. The type of hallucinations the patients are are reporting, that can be a good pointers towards DT, because as I was saying, Lilliputian or frightening, threatening kind of insect hallucinations, those are a feature of DT. Also, the delirium of DT is mostly hyperactive rather than hypoactive. So these are some of the features which can help us determine. But you are right. In some kind of comorbidities, head injury, electrolyte disturbances, picture may be complicated.
In the next line, three questions are asked from
Mhm,
Shefali. What's the difference between tapentadol and tramadol?
mhm.
And if the patient has to be started on long-term therapy of buprenorphine and currently patient is on detoxification phase, will again restart the dose after this detoxification. How to calculate the
Okay,
dose of
okay, okay, okay. Let's take it all these three questions one by one. I can read them. Thank you. Difference between tapentadol and tramadol. Well, both of them belong to the same family. Tapentadol is a newer cousin of tramadol, touted as a safer alternative to tramadol. But as we know, with most of the opioid painkillers as well as most of the sedatives, every new molecule is touted as the safer alternative, but turns out to be, in one way or the other, similar in terms of the risk. So at this moment, tramadol is older, much cheaper, and but in India has been declared as a psychotropic. Tapentadol is relatively newer, more expensive. Till now, Government of India has not declared as a psychotropic, which may affect its availability. But in terms of abuse liability, since tapentadol is new, we perhaps do not see that much tapentadol misuse here in North India. But I know in South, I know in Bangalore, tapentadol is coming across as a major concern, particularly in those situations where heroin is not really easily available on the streets. So that's how it goes. In terms of it, their therapeutic utility, I do not really see tapentadol is a much better therapeutic agent and tramadol. So gold standard from my understanding still remain buprenorphine because of its ease of use. Methadone is also a good agent, but then there are complexities in the way methadone has to be provided, and that's the reason why today I have not discussed methadone, because it would have made the program lengthy, and knowing that many of my colleagues, they would not be able to use methadone in their practice because it requires some special kinds of other kinds of preparations. taking the next question has to be started on long-term therapy of buprenorphine. Currently, patient is in detoxification. We'll again restart the dose after detoxification. Well, yes, you are absolutely right. First point to understand here is to start long-term buprenorphine as a maintenance treatment. Patient need not go through the phase of detoxification. That can be done directly from the day one itself. Heroin to the long-term agonist OST, patient can be shifted directly. They need not come to the zero opioid level for long-term buprenorphine treatment. But I understand that it's maybe that the patient is going through detoxification. It's not yet determined whether patient will agree for a long-term agonist maintenance or not. That can happen. If that is the case, patient is currently in detoxification phase and someone is tapering the dose of buprenorphine, but now the decision is to shift them to a long-term agonist maintenance treatment. We again build up the dose of buprenorphine. We again reach that dose which we think will be the optimum dose of them, which means no withdrawal, no craving, and blocking of exogenously administered opioids. And on that dose, we will continue them. So we need not go through the complete detoxification. Midway, you can increase the dose of buprenorphine once a day, and then you can maintain them on that once a day dose. Third question was how to calculate the dose of benzodiazepine on the basis of standard unit of alcohol consumed. As I said, it's not a very definite kind of thing, but standard drink is equal to 2 milligram of diazepam equivalent. So standard drink, you can find them online. All these formulas about half a bottle of beer, 1 peg of whiskey of 30 ml, 1 glass of wine of 150 ml. All these are supposed to be the standard drinks. So number of drinks that the patient has been consuming in the recent past, not always, in the recent past, they are the good indicator for how much diazepam patients are likely to require. Though this cannot never be a very definite formula that I hope you would understand.
I would like to request Professor Chadda sir. I think I can see his comment in the chat box. So it would be nice, like if Chadda sir tells it. Sir,
Yeah.
over to you, sir.
No, it was an excellent presentation. I think please continue with the question being asked on the chat box.
Okay, sir. Sir, next question is efficacy of tapentadol versus tramadol.
Yeah, as I was saying earlier also, there is really not much to choose from. None of these are supposed to be standard treatment for opioid dependence. These are just poorer alternatives because the good treatment is not available for us. So there is really not much to choose between both of them.
So last is just wondering, is there any evidence of buprenorphine can be used for benzodiazepine dependence, although different receptors are involved?
No, absolutely no. Absolutely no. Buprenorphine, partial opioid agonist, only indication in addiction is supposed to be treatment of opioid dependence, either short-term opioid withdrawals or as long-term maintenance treatment. There is absolutely no pharmacological rationale for using buprenorphine for benzodiazepine or alcohol dependence, right? So I am personally aware of one patient who was patient of alcohol dependence, but outside some other clinician at some other facility started them in their zeal on buprenorphine as their treatment of alcohol dependence, and poor patient then came to us with both need of buprenorphine every day as well as untreated alcohol dependence. So buprenorphine only for opioid dependence.
So I think questions are finished. So I would like to request chairperson for this session, Professor Chadda sir. Acha, there is another question that came, sir. Injectable synthetic opioid who using in a chemical coping manner, for them any oral buprenorphine status as a safer alternative?
Absolutely. When we say buprenorphine is a treatment of opioid dependence, we mean opioid dependence in general. It's not about whether the dependence is on heroin or on some other opioids. If a patient is suffering from tramadol dependence, and on that tramadol they are experiencing many psychosocial complications as well as things like seizures, then yes, sublingual buprenorphine maintenance treatment is a valid treatment for them. Let us not be misguided by the notion that buprenorphine treatment as a maintenance treatment should to be used only when the patient is using heroin and not for other opioids. It's the severity of dependence which would determine the choice of using agonist maintenance treatment or not the agent on which the patient is dependent upon. So it's like nothing too much to choose between whiskey dependence and beer dependence. We do not see people drinking beer every day as somehow less dependent on alcohol than those drinking whiskey. So it's the severity of dependence which matters, not the opioid which they are using. So yes, Dr. Naveen, we can use oral buprenorphine also because it's a much safer alternative than any other synthetic opioid that patient may be using.
So considering no more questions, I would like to request Professor R.K. Chadha sir for his remarks.
Yeah.
Sir. Over to you, sir.
Thank you, Dr. Atul. This was an excellent presentation, well covered. Though we had limited time, I did not expect that this will take so much time because we could not cover non-pharmacological intervention.
Yes.
That was also one of the important
Yes.
area.
Yes.
So we may have that in some future
Yes.
programs.
Sir.
So this was excellent, and we got a lot of questions from the audience, and I think this was one of the best attended program of these 6 sessions, and in which audience has remained till the end. So that's definitely a good achievement, and it's also available on the YouTube.
Sir.
And I thank all the participants who raised queries also, and so it was a very interactive program. So with these comments, I would request Dr. Sood for his last to end the session.
Thank you so much, sir. As you very rightly said, the entire series on psychiatry, I will say, has been very, very successful in terms of the attendance as well as the questions which were asked. And the credit goes to you, sir, selecting the best topic and the best speaker. So we are really grateful to you. Our special thanks to the expert for this evening, Professor Atul Ambekar, sir, for covering this comprehensively very difficult topic, sir. And I think the type of questions and the type of queries which the participants have asked, and you have very nicely answered them. And I'm sure that all of them are very, very satisfied. And the practical tips which you have given to them will be very useful, not only for their clinical practice, but I think also for the examination for the PG student. So NAMS is really very grateful to you for your contribution and for your blessing to the National Academy of Medical Sciences. Thank you so much, and we look forward for your support in future. So again, I would like to place our thanks and the help which we have got from Professor Chadha, sir, who has been our council member as well as the chief coordinator, sir. We are really grateful to you for sparing the time. And I must say that in all the presentations you have been present and you have been making comments and helping us and the students. Thank you so much for your support. We'd like to thank Dr. Jaswant for again moderating this session so nicely and helping us in the background. The participants, especially our senior faculty member and the PG students who have been present throughout the session and asking the question, have made this session very interactive and interesting. So thanks to you also. In the end, before we conclude, I would like to place on record our IT staff, Mr. Anil, who is there, and also Mr. Ravi, who have been working in the background for transmission of this in Zoom as well as on the YouTube. For the information of the student that today we are ending this series on psychiatry, where we had very successful, I think, session. And the next series we are starting from 6th of July, which is on neurology. And the theme is on neurology. And again, we have the chief coordinator from All India Institute of Medical Sciences, Professor Padma. She is head of department, and she has identified the topics as well as the speakers. So the next session, which is due on 6th of July, will be covered, which happened to be Thursday. So please remember, for July, the days is Thursday. So every Thursday, we have this session at 6 o'clock. And the theme which has been selected is on Parkinsonism. So that again is a very important, I think, topic for our PG student. So I will invite the PG student. You can send us the question in advance, which we'll send to the speaker so that these could be covered. And again, I would like to thank all of you who have been helping us in the background and also making this session successful by making contribution, asking question. So once again, thank you very much and good evening. Over to you, Dr. Jason.
Thank you very much, sir. And I would also like to thank you, you and the National Academy of Medical Sciences for giving me the opportunity to moderate this session. Like I'm
Thank you.
too smaller in stature to moderate this session, but
Your contribution is very much appreciated by all,
thank you very much,
including
sir.
the president.
Yes.
Thank you very much, sir. So, with the permission of chairperson of this session, we would like to close this session.
Thank you. Thank you, Dr. Jaswant, Dr. Chadda, Dr. Sood. Thank you for this opportunity.